Hello. Second lecture about drugs for treatment central nervous system, clinical pharmacology of tranquilizers, sedatives, hypnotics, and anticonvulsants. Most drugs that affect the central nervous system act by altering some step in the neurotransmitting process. Drugs affecting the central nervous system may act presynaptically by influencing the production, storage, release, or termination of action of neurotransmitters. Other agents may activate or block postsynaptic receptors. This lecture provides an overview of the central nervous system with a focus on those neurotransmitters that are involved in the actions of the clinically useful central nervous system drugs. These concepts are useful in understanding the etiology and treatment strategies for the neurodegenerative disorder that respond to drug therapy. Parkinson's disease, Alzheimer's disease, multiple sclerosis, and amyotrophic lateral sclerosis. And maybe I say short name, some disease, multiple sclerosis, MS, and amyotrophic lateral sclerosis, ALS, as short names. And first disease, Parkinsonism. It's a progressive neurological disorder of muscle movement characterized by tremors, muscular rigidity, bradykinesia, and postural and gait abnormalities. Most cases involve people over the age of 65, among whom the incidence is about 1 in 100 individuals. The case of Parkinson's disease is unknown for most patients. The disease is correlated with destruction of dopaminergic neurons in the substantia nigra with consequent reduction of dopamine action in the corpus striatum, parts of the brain's basal ganglia system that are involved in motor control. Strategy of treatment. Many of the symptoms of Parkinsonism reflect an imbalance between the excitatory cholinergic neurons and the greatly diminished number of inhibitory dopaminergic neurons. Therapy is aimed at restoring dopamine in the basal ganglia and antagonizing the excitatory effect of cholinergic neurons, thus re-establishing the correct dopamine acetylcholine balance. Currently available drugs offer temporary relief from the symptoms of the disorder, but they don't arrest or reverse the neuronal degeneration caused by the disease. Levodopa and carbidopa. It restores dopaminergic neurotransmission in the corpus striatum by enhancing The synthesis of dopamine in the serving neurons of the substantia nigra. With time, the number of neurons decreases and favorite cells capable of taking up exogenously administers levodopa and converting it to dopamine for subsequent storage and release. The effects of levodopa on the central nervous system can be greatly enhanced by co-administrating carbidopa, dopa decarboxylase inhibitor that doesn't cross the blood-brain barrier. Mechanism of action of levodopa. Because Parkinsonism results from insufficient dopamine in specific regions of the brain, attempts have been made to replenish the dopamine deficiency. Large doses of levodopa are required because much of the drug is decarboxylated to dopamine in the periphery, resulting in side effects. And you can see these side effects. And carbidopa. Actions of this drug. Levodopa decreases the rigidity, tremors, and other symptoms of Parkinsonism. Levodopa in combination with carbidopa is potent and efficacious drug regimen currently available to treat Parkinson's disease. In approximately 2/3 of patients with Parkinson's disease, levodopa-carbidopa treatment substantially reduces the severity of the disease for the first few years of treatment. And pharmacokinetics. The drug is absorbed rapidly from the small intestine when empty of food. Levodopa has extremely short half-life, 1 to 2 hours, which causes a fluctuation in plasma concentration. Ingestion of meals, particularly if high in protein, interferes with the transport of levodopa into the central nervous system. Large neutral amino acid, for example, leucine and isoleucine, compete with levodopa for absorption from the gut and for transport across the blood-brain barrier. Thus, levodopa should be taken on empty stomach, typically 45 minutes before a meal. Withdrawal from the drug must be gradual. And withdrawal adverse effect, peripheral effects, anorexia, nausea, and vomiting occur because of stimulation of the chemoreceptor trigger zone of the medulla. Tachycardia and ventricular extrasystoles result from dopaminergic action on the head. Hypotension may also develop. Adrenergic action on the iris causes mydriasis. Saliva and urine a brownish color because of the melanin pigment produced from catecholamine oxidation. It was peripheral adverse effect, and next, central nervous system effects, visual and auditory hallucination, and abnormal involuntary movements. For example, dyskinesia may occur. Levodopa can also cause mood changes, depression, psychosis, and anxiety. And drug-drug interaction. The vitamin pyridoxine B6 increases the peripheral breakdown of levodopa and diminishes its effectiveness. Concomitant administration of levodopa and monoamine oxidase inhibitors. So it's MAOs such as phenelzine can produce a hypertensive crisis caused by enhanced catecholamine production. In many psychotic patients, levodopa exacerbates symptoms possible through the buildup of central catecholamines. In patients with glaucoma, the drug can cause an increase in intraocular pressure. Cardiac patients should be carefully monitored because of the possible development of cardiac arrhythmias. And antipsychotic drugs contraindicated in Parkinsonian patients. Seleginine and rasagiline. Seleginine, also called the prenyl, selectively inhibits MAO type B at low to moderate doses, but doesn't inhibit MAO type A. While thus decreasing the metabolism of dopamine, seleginine has been found to increase dopamine levels in the brain. Therefore, it enhances the actions of levodopa when those drugs are administered together. Dopamine receptor agonists. This group of anti-Parkinson compounds includes bromocriptine, an ergot derivative, and non-ergot drugs, ropinirole, pramipixole, and rotigotine. These agents have duration of action longer than that of levodopa. Initial therapy with newer drugs is associated particularly with less risk of developing dyskinesias and motor fluctuation when compared to patients started with levodopa therapy. Bromocriptine, derivative of the vasoconstrictive alkaloid. Ergotamine is a dopamine receptor agonist. The dose is increased gradually during a period of 2 to 3 months. Side effects severely limit the utility of the dopamine agonists. The actions of bromocriptine similar to those of levodopa, except that hallucination, confusion, delirium, nausea, and orthostatic hypotension are more common, whereas dyskinesia is less prominent. In psychiatric illness, bromocriptine and levodopa may cause the mental condition to worsen. Serious cardiac problems may develop, particularly in patients with a history of myocardial infarction. In patients with peripheral vascular disease, a worsening of the vasospasm occurs, and in patients with peptic ulcer, there is worsening of the ulcer because bromocriptine is ergot derivative. It has a potential to cause pulmonary and retroperitoneal fibrosis. Apomorphine, pramipixole, ropinirole, rotigotine. So apomorphine is meant to be used for the acute management of the hypermobility of phenomenon. These agents alleviate the motor deficits in both levodopa patients who have never been treated with levodopa, and patients with advanced Parkinson's disease who are taking levodopa. Dopamine agonists may delay the need to use levodopa therapy in early Parkinson's disease and may decrease the dose of levodopa in advanced Parkinson's disease. Nausea, hallucination, insomnia, constipation, dizziness, orthostatic hypotension, among the more distressing side effects of those drugs, but dyskinesia are less frequent than with levodopa. Rotigantine is a dopamine agonist used in the treatment of the signs and symptoms of early-stage Parkinson's disease. It's administered once daily transdermal patch. Next, you know this drug, amantadine. It was accidentally discovered that the antiviral drug amantadine, which is effective in the treatment of influenza, has anti-Parkinsonism action. Amantadine is less efficacious than levodopa, and tolerance develops more readily. However, amantadine has favor side effects. Drug has little effect on tremor, but it's more effective than the anticholinergic agonist rigidity and bradykinesia. Antimuscarine agents. Antimuscarine agents are much less efficacious than levodopa and play only an adjuvant role in anti-Parkinsonism therapy. The action of benztropine, proxycyclidine, trihexyphenidyl, and piperidine. Similar, those individual patients may respond more favorably to one drug. Each of those drugs can induce mood changes and produce xerostomia, dryness of the mouth, and visual problems, as do all muscarinic blockers. They interfere with gastrointestinal peristaltics and contraindicated in patients with glaucoma, prostatic hyperplasia, or pyloric stenosis. Blockage of cholinergic transmission produce effects similar to augmentation of dopaminergic transmission. And you can see adverse effect. Alzheimer's disease and treatment of this pathology. Pharmacologic intervention for Alzheimer's disease is only palliative and provides modest short-term benefit. None of the currently available therapeutic agents have been shown to alter the underlying neurodegenerative process. Dementia of the Alzheimer's type versus the other form of dementia that will not be addressed in this discussion, such as multi-infarct dementia or Lewy body dementia. The three distinguishing features. First is accumulation of senile plaques, is beta amyloid accumulate. Second, formation of numerous neurofibrillary tangles. And loss of cortical neurons, particularly cholinergic neurons. Current therapies aims as an improved cholinergic transmission with the central nervous system or prevention excitotoxic actions resulting from overstimulation of NMDA glutamate receptors in selected brain areas. Numerous studies have linked the progressive loss of cholinergic neurons and presumably cholinergic transmission within the cortex to the memory loss. That is hallmark symptoms of Alzheimer's disease. It's postulated that inhibition of acetylcholinesterase within the central nervous system will improve cholinergic transmission. At least of the neurons that are still functioning. Currently, for reversible HAE inhibitors are approved for the treatment of mild to moderate Alzheimer's disease. There are donepezil, galantamine, rivastigmine, and last tacrine. Except for galantamine, which is competitive, all uncompetitive inhibitors of HAE and appear to have some selectivity for HAE in the central nervous system compared to the peripheral. Common adverse effects include nausea, diarrhea, vomiting, tremors, anorexia, muscle cramps, bradycardia, all of which are predicted by the action of the drug to enhance the cholinergic neurotransmission. NMDA receptor antagonist. Stimulation of glutamate receptors in the central nervous system appears to be critical for the formation of certain memories. However, overstimulation of glutamate receptor, particularly of the NMDA type, has been shown to result in excitotoxic effects on neurons and is suggested mechanism for neurodegenerative or apoptotic programmed cell disease, apoptotic processes. Binding of glutamate to the NMDA receptor assists in the opening of associated ion channel, then allow natrium and particularly calcium to enter the neuron. Unfortunately, excess intracellular calcium can activate a number of processes that ultimately damage neurons and lead to apoptosis. Antagonists of the NMDA glutamate receptor, often neuroprotective prevention, the loss of neurons following ischemic and other injuries. Memantine is dimethyl adamantane derivative. Mechanism acts by physically blocking the NMDA receptor-associated ion channel, but at therapeutic doses, only a fraction of these channels actually blocked. This partial blockade may allow memantine to limit calcium influx into the neuron such that toxic intracellular levels are not achieved during NMDA receptor overstimulation, while still permitting sufficient calcium flow through unblocked channels to preserve other vital processes that depend on calcium or on natrium influx through those channels. This is in contrast to Psychotoxic agents such as phencyclidine, which occupy and block nearly all those channels. In short-term studies, memantine has been shown to slow the rate of memory loss in both vascular-associated and Alzheimer's dementia in patients with moderate to severe cognitive losses. There is no evidence that memantine prevents or slow the neurodegenerative in patients with Alzheimer's disease or is more effective than the HE inhibitors. Memantine is well tolerated with few dose-dependent adverse effects. Expected side effects such as confusion, restlessness, agitation, indistinguishable from the symptoms of Alzheimer's disease. Given its different mechanism of action and possible neuroprotective effects, memantine is often given in combination with HE inhibitor. Long-term data showing significant effect of this combination is not available. Next disease, multiple sclerosis, MS, short name. Multiple sclerosis is autoimmune inflammatory demyelinating disease of the central nervous system. The course of MS is variable. For some, MS may consist of one or two acute neurologic episodes. In other, it's a chronic, relapsing or progressive disease that may span 10 to more 20 years. Historically, medications such as corticosteroids, for example, dexamethasone and prednisone, have been used to treat acute attack of the disease. Other medications that have been used included chemotherapeutic agents such as cyclophosphamide and azathioprine. Never medications that have been approved for the treatment of multiple sclerosis include interferon beta-1 alpha and interferon beta-1 beta as immune system modulators of the interferons and the T helper cells response, which contribute to the inflammatory responses that led to demyelinization of the axon shots. Mitoxantron, the cytotoxic anthracycline analog. Mitoxantron, which can kill T cells, may also be used. The major target of this medication is to modify the body's immune response through inhibition of white blood cell-mediated inflammatory process that eventually lead to myelin damage and decreased inappropriate axonal communication between cells. Adverse effects of the medication may include depression, local injection or infusion reaction. It can be hepatic enzyme increases and flu-like symptoms such as fever and myalgias and leukopenia. Fingolimod is the first oral drug that can slow the progression of disability and reduce the frequency and severity of symptoms in multiple sclerosis, offering patient an alternative to the currently available injectable therapies. Fingolimod alters lymphocyte migration, resulting in a sequestration of lymphocytes in lymph nodes. Fingolimod effective for reducing the relapse rate in patients with MS. However, this benefit is associated with an increased risk of life-threatening infection. Next drug, dalfampridine. Potassium channel blocker administered orally improves walking speeds as placebo. Is the first drug approved for this use. Currently approved MS drug indicated to decrease replace rates or in some cases to prevent accumulation of disability. Next drug, benzodiazepines. It's a large group of drug benzodiazepines. They are most widely used anxiolytic drugs. They have largely replaced barbiturates and meprobamine in the treatment of anxiety because benzodiazepines are safer and more effective. And mechanism of action, the target for benzodiazepine action are the gamma-aminobutyric acid, GABA-A receptors, the benzodiazepine receptor localization in the central nervous system, parallels those GABA neurons. And action. Benzodiazepines have neither antipsychotic activity nor analgesic action, and they don't affect the autonomic nervous system. All benzodiazepines inhibit the following action to greater or lesser. And it's reduction of anxiety at low doses. Benzodiazepines anxiolytic. Next, sedative and hypnotic action. All of the benzodiazepines used to treat anxiety have some sedative properties, and some can produce hypnosis, artificially produced sleep at higher doses. Next, anterograde amnesia. This impairs person's ability to learn and form new memories. Next, anticonvulsant. Several of the benzodiazepines have anticonvulsant activity, and some are used to treat epilepsy. For example, status epilepticus, and other seizures disorders. And next, muscle relaxant. At high doses, benzodiazepines relax the spasticity of skeletal muscle, probably by increasing presynaptic inhibition in the spinal cord, where the alpha-2 GABA alpha receptors are largely located. The individual benzodiazepines show small differences in those relative anxiolytic, anticonvulsant, and sedative properties. However, the duration of action varies widely among this group, and pharmacokinetic consideration are often important in choosing one benzodiazepine over another. And anxiety disorders. Benzodiazepines effective for the treatment of the anxiety symptoms secondary to panic disorders, generalized anxiety disorders, social anxiety disorders, performance anxiety, post-traumatic stress disorders, obsessive compulsive disorders, and extreme anxiety. Sometimes encountered with specific phobias such as fear of flying. Benzodiazepine also useful in treating the anxiety that accompanies some forms of depression and schizophrenia. Drugs should not be used to alleviate the normal stress of everyday life. They should be reversed for continued severe anxiety and then should only be used for short periods of time because of their addiction potential. Long-action agents such as clonazepam, lorazepam, diazepam often preferred in those patients with anxiety who may require treatment for prolonged periods of time. The anti-anxiety effects of the benzodiazepines are less subject to tolerance than the sedative and hypnotic effects. For panic disorders, alprazolam is effective for short and long-term treatment, although it may cause withdrawal reaction in about 30% of sufferance. Diazepam is useful in the treatment of skeletal muscle spasms, such as occur in muscle strain, and in treating spasticity from degenerative disorders such as multiple sclerosis and cerebral palsy. The short-action agent often employed as premedication for anxiety-provoking and unpleasant procedures such as endoscopic, bronchoscopic, certain dental procedures, as well as angioplasty. We're using for amnesia. They also cause a form of conscious sedation, allowing the person to be receptive to instruction during those procedures. Midazolam. Midazolam is a benzodiazepine also used for the induction of anesthesia. Clonazepam, occasionally used in the treatment of certain types of epilepsy, whereas diazepam and lorazepam are the drugs of choice in termination grand mal epileptic seizures and status epilepticus. And sleep disorders. Not all benzodiazepines are useful as hypnotic agents, so all have sedative or calming effect. They tend to decrease the latency to sleep onset and increase stage 2 of non-rapid eye movement sleep. It's REM sleep. Both REM sleep and low wave sleep decreased. In the treatment of insomnia, it's important to balance the sedative effects needed at bedtime with residual sedation upon awakening. Hunger. Commonly prescribed benzodiazepines for sleep disorders include long-action flurazepam, intermediate-action temazepam, and short-action triazolam. Flurazepam. This long-action benzodiazepine significantly reduces both sleep induction time and the number of awakening, and it increases the duration of sleep. Flurazepam has a long action effect and causes little reborn insomnia. Flurazepam and its active metabolites have a half-life of approximately 85 hours, which may result in daytime sedation and accumulation of the drug. Next drug, tamazepam. This drug is useful in patients who experience frequent awakening. However, because the peak sedative effect occurs 1 to 3 hours after an oral dose, it should be given 1 or 2 hours before the desired bedtime. Triazolam. This benzodiazepine has a relatively short duration of action and therefore is used to induce sleep in patients with recurring insomnia. Triazolam is effective in treating individuals who have difficulty in going to sleep. Tolerance frequently develops within a few days, and withdrawal of the gut often results in reborn insomnia, leading the patient to demand another prescription of high dose. Therefore, this drug is best used intermittently rather than daily. In general, hypnotics should be given for only a limited time, usually less than 2 or 4 weeks, and stop it. Okay, it's pharmacokinetics of benzodiazepine and the duration of action. The longer action agents from active metabolites with long half-lives. However, with some benzodiazepines, the clinical duration of action do not always relate with actual half-life. This may be due to receptor dissociation rates in the central nervous system and subsequent redistribution elsewhere. Benzodiazepines excreted in urine. All benzodiazepines cross the placenta barrier and cross to central nervous system of the newborn if given before birth. Nursing infant may also become exposed to the drug in breast milk. And dangerous dependence. Psychological and physical dependence on benzodiazepines can develop if high doses of the drugs are given over a prolonged period. Abrupt discontinuation of the benzodiazepines results in withdrawal symptoms, including anxiety, confusion, restlessness, agitation, tension, insomnia, and rarely seizures. Because of the long half-lives of some benzodiazepines, withdrawal symptoms may occur slow and last a number of days after discontinuation of therapy. Benzodiazepine with a short elimination of half-life, such as triazolam, induce more abrupt and severe withdrawal reaction that seen with drugs that are slowly eliminated, such as flurazepam. Side effect of benzodiazepine. Draw the sinus and the confusions. There are effects, the two most common side effects of the benzodiazepine. Ataxia occurs at high doses and precludes activities that require fine motor coordination, such as driving an automobile. Cognitive impairment can occur with use of benzodiazepine, decreased long-term recall and retention of new knowledge. Triazolam, one of the most potent oral benzodiazepines with rapid elimination, often shows rapid development of tolerance, early morning insomnia, and daytime anxiety, as well as amnesia and confusion. Okay, you can see precaution about benzodiazepines. And next, the role of drug barbiturates. Today, barbiturates have been largely replaced by the benzodiazepines, primarily because barbiturates induce tolerance, drug metabolism enzymes, and physical dependence, and associated with very severe withdrawal symptoms. Foremost is their ability to cause coma in toxic doses. Certain barbiturates, such as the very short-action thiopental, still used to induce anesthesia. Mechanism of action: the sedative hypnotic action of the barbiturates due to the interaction with GABA alpha receptors, which enhances GABAergic transmission. Barbiturates potential GABA action on chloride entry into the neuron by prolonging the duration of the chloride channel openings. In addition, barbiturates can block excitatory glutamate receptors on the static concentration of pentobarbital, also block high frequency sodium channels. All of those molecular actions lead to decreased neuronal activity. Barbiturate classified according to their duration of action. For example, thiopental, which acts within seconds and has a duration of action about 30 minutes, is used in the intravenous induction of anesthesia. By contrast, phenobarbital, which has a duration of action greater than a day, is useful in the treatment of seizures. Pentobarbital, amabarbital, and secobarbital, short-action barbiturates, which are effective as sedative and hypnotic agents, but not anti-anxiety. Not. At low doses, the barbiturates produce sedation, have a calming effect, and reduce excitement. At high doses, the drug causes hypnosis followed by anesthesia, and finally coma and this anesthesia, low of feeling, cause sedation. Thus, any degree of depression of the central nervous system is possible depending on the dose. Barbiturates do not raise the pain threshold and have no analgesic properties. They may even exacerbate pain. Chronic use leads to tolerance. And information about barbiturates. Respiratory distress. Barbiturates suppress the hypoxic and chemoreceptor response to O2, and overdosage is followed by respiratory depression and this. Next, enzyme induction. Barbiturates induce cytochrome P microsomal enzymes in the liver. Therefore, chronic barbiturates administration diminishes the action of many drugs that depend on cytochrome P metabolism to reduce their concentration. And therapeutic uses of barbiturates. Anesthesia. Selection of barbiturate is strongly influenced by the desired duration of action. The ultra-short action barbiturates, such as thiopental, are used intravenously to induce anesthesia. Anticonvulsant, phenobarbital, used in long-term management of tonic-clonic seizures, status epilepticus, and eclampsia. Phenobarbital has been regarded as a drug of choice for treatment of young children with current febrile seizure. However, phenobarbital can depress cognitive performance in children, and the drug should be used cautiously. Phenobarbital has specific anticonvulsant activity that's distinction from the non-specific central nervous system depression. And last, anxiety. Barbiturates have been used as mild sedative to relieve anxiety, nervous tension, insomnia. When used as hypnotic, they suppress REM sleep more than other stages, or most have been replaced by the benzodiazepines. Pharmacokinetics of barbiturates. Barbiturates absorbed orally and distributed widely through the body. All barbiturates redistribute in the body from the brain to the splenic arteries, to skeletal muscles, and finally to adipose tissue. This movement is important in causing the short duration of action in thiopental and similar short-acting derivatives. Barbiturates readily cross the placenta and can depress the fetus. Those agents metabolizate in the liver, and inactive metabolites excreted in urine. Side effect. Central nervous system. Barbiturates cause drowsiness, impaired concentration, mental and physical sluggishness. The central nervous system depressant effects of barbiturates synergies with those of ethanol. Next, drug hangover. Hypnotic doses of barbiturates produce a feeling of tiredness well after the patient wakes. This drug hangover may lead to impaired ability to function normally for many hours after waking. Occasionally, nausea and dizziness occur. Next, precaution. As noted previously, barbiturates induce the cytochrome P system and therefore may decrease the duration of action of drugs that are metabolized by those hepatic enzymes. Barbiturates increase porphyrin synthesis and contraindicated in patients with acute intermittent porphyria. Next, physical dependence. Abrupt withdrawal from barbiturates may cause tremors, weakness, anxiety, restlessness, vomiting, nausea, and seizures, cardiac arrest, and delirium. Withdrawal is much more severe than that associated with opiates and can result in death. And poisoning, barbiturate poisoning has been a leading cause of death resulting from drug overdoses for many decades. Severe depression of respiration is coupled with central cardiovascular depression and results in shock-like condition with shallow infrequent breathing. Treatment includes artificial respiration and purging the stomach of its contents if the drug has been recently taken. No specific barbiturate antagonist is available. Hemodialysis may be necessary if large quantities have been taken. Alkalinization of the urine often aids in the elimination of phenobarbital. And you can see other hypnotic agents, include benzodiazepine, barbiturate, and miscellaneous agents. And now I say to you about hypnotic drugs, zolpidem. The hypnotic zolpidem is not a benzodiazepine instructor, but it acts on subset of the benzodiazepine receptors family. Zolpidem has no anticonvulsant or muscle relaxing properties. It shows few withdrawal effect and inhibits minimal reborn insomnia and little or no tolerance occurs with prolonged use. Zolpidem rapidly absorbed from the gastrointestinal tract, and it has rapid onset of action and short elimination half-life, about 2 or 3 hours, and provides hypnotic effect for approximately 5 hours. You can see adverse effect on slides. Unlike the benzodiazepines at usual hypnotic doses, the non-benzodiazepine drugs, zolpidem, as the piclone don't significantly alter the various sleep stage and hence often the preferred hypnosis. Zaleplon is very similar to zolpidem in its hypnotic actions, but zaleplon causes favor residual effects on psychomotor and cognitive function compared to zolpidem or benzodiazepines. This may be due to its rapid elimination with a half-life of approximately 1 hour. The drug is metabolized by cytochrome 3A4. Ezapicolone. It's oral non-benzodiazepine hypnotic and is also used for treating insomnia. Ezapicolone being shown to be effective for up to 6 months compared to placebo. Ezapicolone is rapidly absorbed, time to peak 1 hour, extensively metabolized by oxidation and demethylation via the cytochrome system and mainly excreted in urine. Elimination half-life approximately 6 hours. And you can see adverse effect. Ramelton. It's a selective agonist at the MT1 and MT2 subtypes of melatonin receptors. Normally, light stimulating the retina transmits signal to the subarachnoid nucleus of the hypothalamus that in turn relays signal via nervous pathway to the pineal gland that inhibits the release of melatonin from the gland. As darkness falls and light cases to strike the retina, melatonin release from the pineal gland is no longer inhibited and the gland begins to secrete melatonin. Stimulation of MT1 and MT2 receptors by melatonin in the central nervous system is able to induce and promote sleep and is thought to maintain the circadian rhythm underlying the normal sleep-wake cycle. Remilton is indicated for the treatment of insomnia in which falling asleep, increased sleep latency is the primary complaint. The potential for abuse of Remilton is believed to be minimal, and no evidence of dependence of withdrawal effects has been observed. Therefore, Remilton can be administered long-term, and you can see common adverse effect of all hypnotics. Next group of drug is antihistamines drugs. Some antihistamines with sedative properties such as hydroxyzine, diphenhydramine, and doxylamine, effective in treating mild form of insomnia. However, these drugs are usually ineffective for all but milder form of situational insomnia. In addition, they have numerous undesirable side effects, for example, anticholinergic effect, that make them less useful than benzodiazepines. Some sedative antihistamine are sold as numerous OTC products. Ethanol is central nervous system depressant, producing sedation and ultimately hypnosis with increasing dosage. Because ethanol has a shallow dose response curve, sedation occurs over a wide dosage range. Is readily absorbed orally and has a volume of distribution close to that of total body water. Ethanol is metabolized primarily in the liver, first to acetylated by alcohol dehydrogenase and then to acetylate by aldehydine dehydrogenase. Elimination is mostly through the kidney, but fraction is excreted through the lungs. Ethanol synergizes with many other sedative agents and can produce severes. Chronic consumption can lead to several liver disease, gastritis, and nutrition deficiency, for example, vitamin B6. Cardiomyopathy is also a consequence of heavy drinking. Drinking. The treatment of choice for alcohol withdrawal is the benzodiazepines. Carbamazepine is effective in treating convulsive episode during withdrawal. Drug to treat alcohol dependence, disulfiram, block the oxidation of acetaldehyd to acetic acid by inhibiting aldehyd dehydrogenase. This results in the accumulation of acetaldehyd in the blood, causing flushing, tachycardia, hyperventilation, nausea. The sulfiram has found some use in the patient seriously desiring to stop alcohol ingestion. Conditioned avoidance response is induced so that the patient abstains from alcohol to prevent unpleasant effects of disulfiram-induced acetaldehyd accumulation. And naltrexone is long-action opiate antagonist that should be used in conjunction with supportive psychotherapy, naltrexone is better tolerated than disulfiram and does not produce the adverse reaction that disulfiram does. Next, acamprosate is agent used in alcohol dependence treatment programs with as yet poorly understood mechanism of action. This agent should also be used in conjunction with supportive psychotherapy. Next, drug for treatment epilepsy. It's expected that seizures can be controlled completely in approximately 70 to 80% of patients with one medication. It's estimated that approximately 10 to 15% of patients will require more than one drug, and perhaps about 10% may not achieve complete seizure control. So, during the past 20 years, the Food and Drug Administration, FDA, has approved many new anti-epileptic drugs. Some of those agents seemed to show potential advantage over drugs approved prior to 1990 in terms of pharmacokinetics, tolerability, and reduced risk for drug-drug interaction. The list of drugs approved since 1990 includes Felbamate, gabapentin, lacosamide, lamotrigine, levetiracetam, pregabalin, oxcarbazepine, rufinamide, topiramide, tiagabin, zonisamide, vigabatrin. They are labeled second generation when compared with other antiepileptic, such as carbamazepine, etosuximide, divalproex, phenytoin, phenobarbital, and valproic acid. However, several studies have failed to provide sufficient evidence that the second generation drugs are significantly better than the older agents in terms of efficacy and lack of adverse effects. For that reason, the most commonly used anti-epileptic drugs are described in alphabetic order rather than attempting to rank them by efficacy. Common adverse effect of the anti-epileptic drugs: those drugs with increased risk of suicidal behavioral and suicidal ideation require an FDA black box warning on the label. So, short information about a different group of drug for treatment epilepsy. Benzodiazepines bind to GABA inhibitory receptors to reduce ringing rate. Diazepam and lorazepam, most often used as adjunctive therapy by myoclonic, as well as for partial and generated tonic-clonic seizures. Lorazepam has shorter pharmacokinetic half-life, but stays in the brain longer than diazepam. Diazepam is available for rectal administration to avoid or interrupt prolonged generalized tonic-clonic seizures or clusters. Other benzodiazepines may be used in the treatment of various epilepsies, but should be considered for use only after trial with monotherapy or combination of most other medication for treatment of seizure fail. Carbamazepine reduce the propagation of abnormal impulses in the brain by blocking sodium channels. Therapy inhibiting the generation of repetitive action potentials in the epileptic focus and preventing their spread. Carbamazepine is effective for treatment of partial seizures and secondary generalized tonic-clonic seizures. It's also used to treat trigeminal neuralgia and bipolar disorders. Carbamazepine is absorbed slowly and erratically following oral administration. It may vary from generic to generic, resulting in large variation in serum concentration of the drugs. It induces its one-drug metabolism and has active metabolite. Its substrate for cytochrome P3A4 with minor metabolism by cytochrome P1A2 and cytochrome 2C8. It's not as well tolerated by the elderly as available anti-seizure medication. Hyponatremia may be noted in some patients, especially the elderly, and could indicate a need for change of therapy. A characteristic rash may develop early in therapy but may not require a change in treatment. Carbamazepine should not be prescribed for patients with absent seizures because it may cause an increase in seizures. Etasuximide reduce propagation of abnormal electrical activity in the brain, most likely by inhibit T-type calcium channels. It's effective in treating only primary generalized absence seizures. Use of etasuximide is limited because of this very narrow spectrum of activity. Next drug, felbamate. Felbamate has a broad spectrum of anticonvulsant action. The drug has multiple proposed mechanisms, including, and you can see this mechanism action. It's an inhibitor of drug metabolized by cytochrome 2C19 and beta oxidation and induces drug metabolized by cytochrome P3A4. Is reserved for use in refractory epilepsies because of the risk of aplastic anemia and hepatic failure. Refractory epilepsies is partiality Lennox-Gastaut syndrome. Next drug, gabapentin. It's analog of GABA. However, it doesn't act at GABA receptors and it neither enhances GABA action nor is converted to GABA. It's approved as adjunct therapy for partial seizure and for treatment of post-therapeutic neuralgia. Gabapentin doesn't bind to plasma proteins and excreted unchanging through the kidneys. Reduced dosing is required in renal disease. Gabapentin has been shown to be well tolerated by the elderly population with partial seizures due to its relatively mild adverse effects. It may also be a good choice for the older patient because there are limited or no reports associated pharmacokinetic drug interaction. Lacosamide. In vitro effect, voltage-gated sodium channels resulting in stabilization of hyperexcitable neuronal membranes and inhibition of repetitive neuronal firing. Next, lamotrigine. It's approved for use in bipolar disorders as well. Lamotrigine dosage should be reduced when adding valproate to therapy, unless the valproate is being added in a small dose to provide a boost to the lamotrigine serum concentration. Repeat titration to high serum concentration of lamotrigine have been reported to cause a rash, which in some patients may progress to serious life-threatening reaction. Lamotrigine has also been shown to be well tolerated by the elderly population with partial seizure due to its relatively minor adverse effect. And levetiracetam is approved for adjunct therapy of partial onset seizures, myoclonic seizures, and primary generality tonic-clonic seizures in adult and in children. Next drug, oxcarbazepine is produced. It's approved for use in adult and child with partial onset seizure. Next, phenobarbital using 2. Next, phenytoin and phosphenytoin. Phenytoin effective for treatment of partial seizure and generalized tonic-clonic seizures and in the treatment of status epilepticus. Drug is 90% bound to plasma albumin. Phenytoin-induced drug metabolized by the CYP2C and CYP3A families and the UGT enzyme system. Phenytoin inhibits saturable enzyme metabolism at low serum concentration. Therefore, knowledge of zero-order pharmacokinetics and population parameters is important for dosing adjustment. Small increases in a daily dose can produce large increases in the plasma concentration, resulting in drug-induced toxicity. Long-term use may lead to development of peripheral neuropathies and osteoporosis. Also, phenytoin is a drug used most commonly worldwide for epilepsy due to its low cost per table. The cost of therapy may be much higher when the potential for serious toxicity and adverse effects is weighed. Phosphenytoin is produced and is rapidly converted to phenytoin in the blood reaction, high levels within minutes. Phosphenytoin may also be administered intramuscularly. However, phenytoin sodium should never be given intramuscular because it can cause tissue damage and necrosis. Phosphenytoin is a drug of choice and standard of care for intravenous and intramuscular administration because of sound alike and look like trade names. There is a risk for prescribing errors. Next drug, we can use pregabalin, valproic acid, and divalproex. Valproic acid is available as a free acid. Divalproex, it was developed to improve gastrointestinal tolerance of valproic acid. It's a drug effective for treatment of partial and primary generalized epilepsies. Valproate inhibits metabolism of the cytochrome P2C9 UGT and exposite hydrolase system. Valproate is bound to albumin greater than 90%, which can cause significant interaction with other highly potent bound drugs. Rare hepatic toxicity may cause rise in hepatic enzymes in plasma, which should be monitored frequently. So it's all. Thank you for your attention. Bye.